So a couple of things, if you look at the front of the handout, there are guidelines posted. You'll find 3 of them posted under heart failure on D2L. So the last major update was on, I shouldn't say, the last major guideline came out in 2013. They have done 2 focused updates, one in 2016, one in 2017. So anytime they have clinical trials that change the way that drug therapy should be used, they'll usually do a focused update. And so they did that last year. So those are all 3 done. Your handout for the most part reflects the 2017. In almost everything, maybe one in the end when it talks about aldosterone receptor antagonists, but I'll point that out as we go through. So this one has lots of objectives.
Sorry. No.
So most of these drugs you have seen before, not all of them, but most of them. So similar contraindications, similar side effects, similar dosing issues, and we'll go through all of those as we go through. So we're going to apply them now to heart failure. So tell me what you've learned on what have you learned about heart failure? Expensive to treat? Okay. How so?
Congestive heart failure has a higher readmissions rate.
Has a high admissions rate. So one of the things and one of the outcomes with drug therapy is reduce that. People who are admitted to the hospital usually aren't well controlled, so it tells you that there needs to be a step up in therapy, if at all possible, in order to control that. So it's one of our outcomes. So we don't tend to use the word, they prefer not to use the word congestive heart failure anymore, the word is heart failure. And now we even have other ways to describe it, which you probably talked about, preserved ejection fraction, okay. And they've even broken that down in the 2017 guidelines, they even broke it down into further based on ejection fraction. Okay, what else have you learned?
Usually on diuretics.
Usually on diuretics. Which patients do you get on diuretics? Does everybody need to be on them? Most of them are, so they got to be volume overloaded. Okay, all right, what else? Preserved or hard to treat, why is that?
They don't always have the, like, it sounded like it was like less responsive.
Yeah.
Okay. All right, so harder to treat. What else?
It can cause like peripheral edema or like JVD.
Okay, so some of the physical signs that you can look at. What else? There's 3 of them in general. JVD, peripheral, pulmonary. So think about the places where fluid's going to back up that you usually can find it. Lungs. Okay, right. So to me, the term heart failure is a scary thing to say to patients. Okay, so be careful when you do that. It's like failure. So we only use that with about three organs. Kidney failure, liver failure, heart failure. Okay. So what does that mean? When we are saying it, what are we talking about?
Yeah, ejection fraction below a certain threshold.
Failure to supply the body tissues with enough oxygen. Okay. Sometimes irreversible. So failure in that the organ is declining in function to the point where it can no longer meet the needs of the body. Okay, very good. All right, anything else? You will see it a lot. It is a disease of aging for the most part. What are some of the common risk factors? What's some of the common causes? Smoking.
Diabetes.
Smoking. What's probably the #1 cause? Hypertension. That's why it's important to pay attention to hypertension and to treat it. To the point where we can normalize it and not cause people trouble. So always that balance. But hypertension really needs a lot of good attention. Okay. So let's do some reviews. So you talked about some of the symptoms. So you've got usually an enlarged heart, and it leads to those symptoms of peripheral edema. Why is it down in the feet? Gravity, okay. And the lungs we talked about. And we also see it in the liver. Okay, so let's look at the pathophysiology. That one didn't come up? Did it come up?
It's on, it just takes a little
Okay.
bit.
Okay, so whenever you have some type of injury or change in the heart, then the body is going to do things to compensate. Because when the heart can no longer pump enough blood to meet the needs of the body, how do the kidneys look at that? What happens to the kidneys? They're trying to compensate. Why?
Because they think that decreased blood.
They think there's not enough volume. So it is a decrease in effective circulating volume. So what do the kidneys do? They will activate that renin-angiotensin-aldosterone system, right? If there is one system that would be very important for you to learn, you really do need to understand that system. It affects lots of things, and we impact it with our drugs. Really important one to understand. If you don't, you're never going to understand heart failure or hypertension to the extent that you should. You also get an activation of the central nervous system, or the sympathetic nervous system, right, to maintain cardiac output. So then, what are the results of that? Heart rate goes up, contractility goes up, right, to keep the pumping going. So if cardiac output falls, what can the heart do? What are the determinants? So it's going to increase heart rate, right? So that's where that comes from, all right? So then, out of the renin-angiotensin system, you get vasoconstriction, mostly from what reason? What's causing that? Angiotensin 2, okay. And so angiotensin 2 vasoconstricts because the body's going to respond to a decrease in circulating volume by vasoconstricting areas that aren't as important and keeping blood flow to the areas that are important, right? Keep the body alive. Keep the brain alive, you know, kill the brain, kill the ghoul. So keep the brain alive, you can keep the organism going. So, and then angiotensin 2 has effects to increase volume, and how does it do that?
Fluid retention.
Aldosterone. So where does aldosterone come from? Which part of the adrenal? The cortex. Now you should be able to tell me what layer it comes from. No, not the middle layer. Oh.
We were doing so well.
GFR,
Oh,
the 3 layers, right? Remember that? We talked about salt, sugar, sex.
Yeah.
Okay. So the G layer is where the mineralocorticoids come from. What's the name of that one? Have you slept since then? Okay, glomerulosa. Glomerulosa, fasciculata, reticularis.
oh man.
Okay, let's see. So we get a volume expansion because aldosterone works where? Where does it exert its effect? Kidney. Okay, what part of the kidney? The nephron, right? Okay, what part of the nephron? Collecting tubule. So think about, okay. All right, so all of those are compensatory mechanisms to maintain cardiac output, but at some point, it can no longer keep up with demand. So we're going to talk about all the drugs that will affect this failure pathophysiology in order to decrease those symptoms and prolong life. Okay, So this, I like this because it shows you normal circulation, and then it shows you what happens when you have pump failure and the backup in that pulmonary circuit, and why that leads to pulmonary congestion, but also why you get that vasoconstriction that then can lead to edema in the periphery. So I pulled a couple of slides. We've talked about this before, about the importance of hydrostatic pressure, right? Okay. So when you're looking and going from an arterial end to the venous side through the capillary bed, you've got an increase in hydrostatic pressure coming in, right? Okay. And then you have, and the steady part here is what? The steady pressure that doesn't change. Oncotic pressure. You also have interstitial pressure, and those all maintain constant. So initially, the hydrostatic pressure is going to be higher than them, so the fluid will exit. Over the point is that as that pressure decreases, then the fluid will move back in. So that's happening in you every day, all the time, and that's why you don't have peripheral edema. I like this one too, because it shows you the changes in pressure from the arterial side to the venous side. So here's arterial pressure, mostly accounted for by hydrostatic pressure. You see that the oncotic pressure is steady, and the interstitial pressure. So over time, water comes out here, and then when the pressure is higher in the vascular space, it moves back in. Okay. Questions about those? It works. It's good. It's good to know. All right. So here's your systolic functions and diastolic functions. So in systolic functions, what's the major problem? Got enlarged ventricles and your ejection fraction, which is what? What are we talking about when we're talking about ejection fraction?
The amount of blood pumped out by one ventricular contraction.
So the amount, or not so much the amount, but the percent of blood that's ejected from the ventricles, right? So it's not 100%, right? So that's systolic. And then here is the diastolic. This is the one you were talking about with preserved. So you've got stiffened ventricles. They don't work as well. And so they still pump out and maintain an ejection fraction, but the person can still have symptoms of heart failure. What's a normal ejection fraction?
Anything above
55 to 70 usually is a percent that'll be. All right. Here are all the different causes. You mentioned heart problems, but there's lots of problems. So you can have pulmonary problems, heart problems, so heart valves that aren't working anymore, rhythm disturbances. What would be a common arrhythmia that would could cause failure symptoms? Atrial fibrillation, right? Heart muscle defects. Other disorders of the heart, coronary artery disease, ischemic heart disease, another very common cause of heart failure. After people have an MI and they have heart muscle that no longer works very well, they can develop failure. Other medical conditions, so anemia. Anemia usually has a high output failure because the heart will just speed up to keep moving blood around that is oxygenated. Kidney disease, often associated with failure. Diabetes, very common. In fact, diabetes falls into that stage A as no known heart failure, no structural damage that can be seen, but is considered a precondition for congestive heart failure. Obesity, thyroid disorders, either spectrum, either hyperthyroidism or hypo. So lots of causes for heart failure. Let's see. So this shows you that for adults over 20, you've got the 20 to 40-year-olds, 40 to 60-year-olds, 60 to 80, and then above 80. Males are in blue, females are in red. What do you see with that slide? Aging, so it goes up with age.
Slightly higher now.
Slightly higher in males.
Yeah.
Right, but then they die off, and so we see more in. Okay, so a big change here, right? Okay, so here's where a lot of metabolic and heart disease will start showing up, and then you start seeing the ramifications of those. Okay? Here's another one. Lifetime risk for heart failure, indexed by blood pressure and sex. Here's men. Let's see, on this axis, it's the, sorry, I can't read it right there. So on your y-axis, you have lifetime risk for heart failure, so it's a percentage. And on your x-axis, you have men and women. And then they divide each of these into blood pressure. This is normal, so less than 140 over 90. This one is 140 to 160 over 90 to 100, and this is greater than 160, greater than 100. So what do you see with that one? Blood pressure makes a huge difference. Pay attention to it, treat your patients. Educate them. Things that affect heart failure, lifestyle, those things. Always be drumming that message. Okay. If we look at the different stages of heart failure, so did you all talk about A, B, C, and D? No? Okay. I've got them in your handout. So the one we're going to be talking about today is mostly C. So you can see that the more severe the heart failure, the higher the mortality, lower survival rate. So those with the most severe, about a 5-year survival rate. And with the C, which are the ones we're going to talk about mostly today in terms of treatment, really depends on the amount of treatment, the amount of structural disease they have. A and B are the least. A would be those people without heart failure but have high risk for it, like diabetes. These are the targets for prevention. So there's a lot more talk in the heart failure literature now about prevention. So now we know more, and we can tell which hearts are at risk or what factors now are most contributory. Now there's going to be a lot more evidence being sought and interventions that will prevent. So that's going to occur more in your professional lifetime. Okay, in terms of treatment, the American Heart Association, American College of Cardiology divide the patients into stages A, B, C, and D. Did y'all talk about these?
We did the New York.
Okay, so what's New York? What does New York tell you?
Severity based on
Functionality?
Yes.
Okay. So these are looking at people who are at risk and how they should be treated. So mostly it's going after risk factors and treatment of hypertensive heart disease. C and D are folks with heart failure, and that's, I just wanted to show you where it's going to fall because this is the ones we're going to talk about today. Okay. So let's look on page 3, cardinal manifestations of heart failure. Short of breath, fatigue. Why are they fatigued? Okay. They have limited exercise tolerance. Why is that? Fluid retention, we've talked about. They have pulmonary or splenic congestion, so gut. They may have nausea. They may not absorb drugs very well because of that. And may or may not have peripheral edema. Okay. So heart failure, common clinical syndrome resulting from structural problems or functional cardiac disorder that impairs the ability of the ventricles to fill and eject blood. So there's your definition. All the diseases, or some of the diseases, common ones are listed there. Patients can present with or without signs of volume overload. Again, we prefer the term now heart failure instead of congestive heart failure. And now and there's even more than these. Again, we're just going to state these two major types. So heart failure with reduced ejection fraction, that's what we're going to talk about today. So this is due to left ventricular dysfunction, also referred to as systolic heart failure, and defined as an ejection fraction less than 40% or less. The preserved are referred to as diastolic dysfunction, left ejection fraction is greater than 40%. The new guidelines have broken this down further into three categories now, based again on ejection fraction. The other reason they'll break them down is based on how they're responding to therapy in the clinical trials, is another reason for that distinction. So there are stages of heart failure. These are objective. These are things that you can measure. I'm gonna ask you these, and just so you have more of the vernacular down. So these are structural heart disease and symptoms. So if you go down through stage A is no objective evidence of heart failure, but these are people at risk. Diabetics would fall into this category simply by nature of having the disease. No symptoms, no limitations. Stage B are minimal cardiovascular disease, mild symptoms, mild limitations. C, you get the pattern here. Moderate to severe, much more symptomatic, much more limitation of activity, and then D would be the most extreme. The one that you've been looking at is functional capacity, and that's on the next page, is the New York Heart Association. So it's looking at what can the person do. And we've used this one for a long time, so you'll see it referred to quite a bit in the guidelines, class, New York Heart Association class 2 through 4, usually are the ones we're looking at. So these have, we'll use, some of the drugs are indicated based on this classification system. So the ability to do physical activity is what is primarily driving this one. Here are some examples. I took this off the the American Heart Association page. So how this might play out. So a patient who had minimal or no symptoms, but a large pressure gradient across the aortic valve or severe obstruction of the left main artery is classified as functional capacity 1. Okay, so that's New York Heart Association 1, and objective D. So flip back there and look at what D is. Okay. Refractory, symptoms, severe limitations, experience symptoms while at rest. Look at the other one. Patient with severe anginal syndrome, but angiographically normal coronary arteries, classified as functional capacity 4, objective assessment A. So A goes back to no structural evidence, but you get severe limitation. I am not going to ask you those. That's someone else's purview, but things to keep in mind and to at least be conversant with those terms. Recommendations for preserve. This is the only little section I'm going to add in here. The big thing is going after blood pressure with this group. Do we change our blood pressure goals for this group? What are the goals for these folks?
If they're less than 60, it's 140 over 90, and if they're greater than it's 150.
I think the goals here are less than 130 over 80 by the Heart Association guidelines.
Yeah.
I'll verify that.
Is that just specifically for heart failure?
The new one where they're trying to sell pumps.
I'll check it since you all seem to have
What is it, JC?
Whose recommendation?
JNCA?
This is American Heart Association guidelines, not JNCA. Okay, diuretics, we are using those for volume overload just like we're going to do for the other groups. Coronary revascularization for patients who have ischemic causes. for those who have been arrhythmias, atrial fib in particular. We're going to use the same drugs. So for their ischemic symptoms or their blood pressure, we're going to use the beta blockers, ACE inhibitors, or ARBs. That's because they have been demonstrated to decrease morbidity and mortality. This is new. The next section came out of the 2017, is to add an aldosterone receptor antagonist to decrease hospitalizations. Also consider ARBs for patients who are having frequent hospitalizations. Okay. So does any of that conflict with what you learned yesterday? Okay.
130 or 80.
Pardon?
130 or 80.
Okay, so now we're going to move into the section on reduced ejection fraction. So our goals here is we want to reduce morbidity, reduce mortality, because we've got these folks who who have a high risk of not surviving 5 to 7 years, right? So we want to move them back up that, back to the left. So reducing symptoms, we're going to do that through medications. And a lot of these drugs have been shown to reduce morbidity. Also to reduce mortality. A lot of them have shown to improve survival. Get them out of the hospital, keep them out of the hospital, keep them more functional. Goals of treatment: improve symptoms, slow or reverse the damage to the myocardium, and reduce mortality. All patients are going to be treated with an ACE inhibitor or an ARB or the ARNIs, and we'll talk about those a little bit later, and they'll be on a beta blocker. Patients are volume overloaded. We'll say this numerous times. We'll use loop diuretics. For African Americans, we'll look at a special drug category which combines a potent vasodilator, hydralazine, with nitrates. And if their kidneys are functioning well and they are not hyperkalemic, we'll add an aldosterone receptor antagonist. Look at the next 2 pages. This came out of the 2016 guidelines. It gives you the recommendations and it gives you the evidence. You don't have to memorize this table, but I would often look back at it. Okay? Where you see the A's over at the side, that's the highest level of evidence. That means there is clear evidence that that intervention leads to reduction in mortality and morbidity. I didn't put the 2017 in because it wasn't as complete, and they only added in the things that are different from the 2016. The big change here is that the classification called ARNI, which is a ARB with naproxen, which is impacts or negates the effects of the natriuretic proteins. That has moved up in category to the same with ACEs and ARBs. And for people who are stable on those that continue to have symptoms, they recommend switching them to those drugs because the mortality and morbidity decreased by 20% even in those people who have been on an ACE and an ARB. So I'm just pointing out a difference. I will point that out again when we get to that class of drugs. You'll see that on the second page it even addresses other issues. So it talks about the addition of statins, using omega-3 supplements, using other nutritional supplements, and calcium channel blockers. So it's more than just the drugs that we use to affect the symptoms. Okay. Next page, page 8, on diuretics. So diuretics may be one of the first drugs used because the patient is presenting with fluid overload, or they have decompensated and now they are fluid overload. The only drugs that can effectively remove them are the diuretics. The other drugs, once you have them stabilized, may help maintain them, but The only drug that's going to remove the fluid are this class of drugs. So symptoms of volume overload you're familiar with, dyspnea, so shortness of breath, peripheral edema. These symptoms, as long as the patient is responsive, can be they'll quickly respond can be hours, could be a few days, depends on how overloaded they are, how decompensated their system is. We use the loop diuretics, so there's lots of diuretics. You've learned about, what other kind of diuretics have you learned about? Thiazides, okay. Thiazides are not potent enough in heart failure to mobilize a lot of extravascular fluid, can't do it. Because it's very dependent, where do those drugs work? Okay, the thiazides work with blood pressure, they work in the arterioles, but they also work in the nephron. Where do they exert their effect? No, they're the distal tubule. So often in people who have heart failure, they cannot deliver enough of the drug or sodium to that distal tubule to make it to be effective. So those drugs are not effective in moving lots of extravascular fluid. That's why we use the loops. They are the most powerful, some of the most powerful. If you look at that diagram, let me show you this one. Medical stage benefit for stage C, these are the magnitude of the benefit. So you've got ACE inhibitors and ARBs, beta blockers, aldosterone antagonists. So look at the relative risk reduction in mortality. So it's not a percent, 17%, it's relative risk reduction. So ACEs and ARB reduced by 17%. The number needed to treat, have you all talked about that? This means how many patients with this disease do you have to treat to get the outcome you're looking for? So 26 may sound like a lot. In the whole scheme of things, it's not. So you have to treat 26 people to see the outcome you want. Relative risk reduction in hospitalizations, 31%. That's significant. Beta blockers, reduction in mortality, 34%. Number needed to treat, 9. That justifies treatment. 41% reduction in hospitalization. Aldosterone antagonists, 30% reduction in mortality. Number needed to treat, 6, gold. Hydralazine nitrates, 43%. This is the African American population, 7, 33% reduction in hospitalizations. That's why these drugs form the base, the cornerstone of treatment. That's why all patients should be placed on them unless there's some compelling reason not to, because the evidence behind them is strong enough to justify putting them on it. Most of these drugs are also very cheap. It doesn't cost, that's why when you said it cost a lot, it doesn't cost a lot to do the medicines, it costs a lot if they have to go in the hospital. So keeping them out. So that's why these are the drugs we're going to focus on. Okay, so let's look at the nephron. So the functional unit of the kidney, right? The nephron.
2 minutes.
So we're looking at the cortex, the outer portion of the kidney, down to the outer medulla and the inner medulla. So those nephrons transverse all those layers. And the strongest part of that nephron is down here in this section that gets down into the inner medulla. This is the loop of Henle. So the loop of Henle, so blood flow is coming in through that Bowman's capsule, right? You have a capillary network where fluid and filtration occurs. The filtrate enters in through the proximal tubule, right? Why is it the proximal tubule? Closest to the start. And then we have this loop of Henle, and then we have the distal tubule, and then we have the collecting ducts. Is it on there? Doesn't have the collecting duct. Okay. So in the loop of Henle, what do you see in that descending loop? Okay. Water leaves. So that descending loop is permeable to water, not to sodium. So sodium stays in there. Okay. So you see a concentrating effect as you go down through, right? What do you see in the ascending loop? Is it permeable to water? No. So sodium leaves, and we see a decrease in tonicity until we get up there to the distal tubule, and then you get a hypotonic fluid. So you're peeing out of more. So really, evolutionary wise, we want to keep holding on to fluid, right? We don't want to just pee out all the water we take in too much. So if we do that, we would become dehydrated, right? So this is a way for some sodium excretion and to hold on to volume. Okay, you all are really dragging. Do you need to get up and move around? Okay, go take a break and bring your brains back when you come. So let's take a 10-minute break. We'll come back about 1:45.
I didn't know she just like the clock.